Hi friends, Namaste. Are you curious to know the new advances in bone marrow transplant? Friends, technology is changing every day. And to remind you, healthcare is not behind. The protocols have changed so widely that even bone marrow transplant is just the name of the treatment and no one aligned with it. What's the first thought that comes to your mind when you hear bone marrow transplant? Yes, what you thought is right, but outdated. Similarly, there are so many facts that were considered as facts earlier, but are considered as misconceptions now on bone marrow transplant. Right from the time that is correct to get a bone marrow transplant, is it safe for the donor, risk factors, expected outcomes, etc., etc. Today in this video, you will have the authentic answers to all the advances and misconceptions from one of the well-known doctors of West India. Before we get started, I am Dr. Khushbu Jain from MedicoExperts, and this video is a part of the patient education program of MedicoExperts so that you can make an informed decision. Friends, today I am going to establish clarity on different aspects of bone marrow transplant. In this discussion, we have one of the best hemato-oncologists of West India, Dr. Subhaprakash Sanyal, having a vast experience of more than 15 years in the field of diagnosis and treatment of patients with hematological diseases including hemato-oncology, acute leukemia, chronic leukemia, myeloma, lymphoma, bone marrow failure syndromes like aplastic anemia, myelodysplastic syndrome, etc. He is an expert in the management of hemoglobinopathies like thalassemia, sickle cell anemia, including their prenatal diagnosis and genetic counseling. He carries a special interest in obstetrics, hematology, and thrombosis disorders. He is a director of hematology, hemato-oncology, and bone marrow transplant of Fortis Mulund Center in Mumbai. He also heads the FIBD that contains various professionals that include hematologists, other trained professionals, bonding medication specialists, and an exceptionally strong devoted nursing group which deals with very bustling indoor and open air office. Welcome Dr. Sanyal to the MedicoExperts Patient Awareness Initiative. There's a big confusion as to what is transplanted and what bone marrow transplant is. So could you please explain to the global audiences as to what is bone marrow transplant?
So first of all, bone marrow transplant is not related to any surgery. This is the one common myth we always get, because when you hear about the heart transplant, lung transplant, kidney transplant, there is some surgery involved, right? But here there is no surgery involved at all. And whenever the transplant word is used, there are two types of transplant we talk about. One is the autologous transplant, one is the allogenic transplant. So whenever autologous transplant means when the donor is himself or herself or the patient itself. So patient is himself is the donor, okay? So that we call autologous stem cell transplant. And whether the donor is either family sibling or some unrelated matched donor or some half donor from the family, that we call, these are all actually comes into the category of allogenic stem cell transplantation. So autologous stem cell transplantation, allogenic stem cell transplantation. There are two types of transplantation. So autologous stem cell transplantation, the donor is himself, and allogenic stem cell transplant, there is a healthy donor other than the patient. Very simple. So when we talk about the autologous stem cell transplant, basically the main job or main effect of the treatment actually given by a chemotherapy combination. Different type of disease, different type of chemotherapy we use. Suppose in multiple myeloma, we use only melphalan chemotherapy. In lymphoma, we use the beam chemotherapy. So basically this chemotherapy does the job. But this chemotherapy is so heavy that it will kill your stem cells completely. So you have to make some arrangement or you have to make some adjustment of your body so that you should have a marrow recovery. Okay? And how to get that? So you collect the normal stem cell, you give them the chemotherapy, then you inject the stem cell to the patient's body, and then after 8-10 days down the line, your new stem cells started functioning well. And that way you can produce hemoglobin WBC, healthy hemoglobin WBC platelet count like that. So that is called autologous stem cell transplantation. That is the reason nowadays people call it high dose chemotherapy followed by stem cell rescue. This means you are giving high dose chemotherapy and now you are rescuing the body with the help of stem cells. That is why it is called high dose chemotherapy followed by stem cell rescue. One more point I want to emphasize very clearly in our organ system, what we do as a hematologist, the stem cells what we use, that is called hematopoietic stem cells. What does it mean? That stem cell will produce only hemoglobin, WBC and platelet, nothing other than these three components. There is no muscle formation, no nerve formation, no organ formation like that. So it's a hematopoietic stem cell transplantation. That is why many people nowadays it is called autologous peripheral blood stem cell transplantation. Because we don't collect the peripheral blood stem cells in the lymphoma myeloma from the patient's bone marrow anymore. We collect from the just peripheral blood, a very simple technique called apheresis. You are quite accustomed with the terminology called apheresis, that we collect the platelet donation and everything in the blood bank very commonly. It's the same technology or same technique we follow in our ward to collect the stem cell. So there is no surgery involved. We don't collect mostly from the bone marrow, we collect from the peripheral blood. That is why bone marrow transplant ward is also now obsolete. It is called peripheral blood stem cell transplantation. So that is the way things are. Allogenic stem cell transplant means there is a marrow disease. You just destroy the marrow, make some space given the stem cell, and then exploit the graft versus leukemia effect, which is GVL effect, which is immunological mechanism. You just keep the disease away from your system. That is the main principle about this.
Thank you, sir. Thank you for a distinct explanation to our audiences. I hope it is very clear to all the friends watching what BMT is. If I need to summarize, it is basically replacement of bone marrow that is not producing enough healthy blood cells. Am I right, sir?
Yes, to some extent you are definitely right. But see, I told you, the autologous stem cell transplant, basically there is a disease in your body like a myeloma or lymphoma. You are using a chemotherapy, which actually a treatment for the disease, but as a collateral damage, your bone marrow gets totally destroyed. So you want to rescue that destroyed organ with the help of the stem cells. So that is why the autologous stem cell work. That is why we call it high dose chemotherapy followed by stem cell rescue. Allogenic stem cell transplant, what we are saying, that your bone marrow is not functioning. So you have to change the whole stuff, or change the entire microenvironment. So basically you are destroying the marrow, make the space, you need some space, right? When you give the stem cells, you need space. You give the stem cells and they started functioning, and then ultimately there is a graft versus leukemia GVL effect, which keeps the disease under control, like that.
Okay, sir. So the next question is, what are the medical conditions specific to BMT? I mean, where is BMT typically recommended? What are the key factors that influence the decision for a patient regarding BMT?
So Dr. Pushpa, is very simple. It is very disease specific. What disease you have? So autologous stem cell transplantation, we generally do mostly in two conditions in hematology. One is a multiple myeloma and one is a relapsed lymphoma, any type of lymphoma, Hodgkin's, non-Hodgkin's, like that. So these are the main two indications. There are some other indications like a neuroblastoma. There are some non-hematological disorders like multiple sclerosis, scleroderma, like that. There also you can try autologous stem cell transplantation. Allogenic stem cell transplant, again, hematological, non-hematological. So it's a benign hematology versus malignant hematology. So in malignant hematology, leukemia, the blood cancer, myelodysplastic syndrome, when the bone marrow is not working efficiently, then comes the aplastic anemia, you comes the thalassemia, you come the myelofibrosis. There are a lot of hematological malignancies where we concentrate on doing the allogenic stem cell transplantation.
Okay, sir. Which means BMT has a wide range in terms of treatments, basically, that can be helpful.
Yes.
So the next question is, sir, mostly people have understood that later the transplant is done, better it is for the children, as they cannot undergo BMT. Is that true?
Sorry, just can you repeat the question once?
Later the transplant is done, better it is for the children, as the children cannot undergo BMT.
No, I don't agree with this statement. So when patient needs transplant, you have to go for transplant. So very interesting that children's body immune system, children organ system is much better I would say the word much healthier than the adult one. And we see our day-to-day practice that the challenges of the chemotherapy or challenges of the other intensive treatment, the children accept more boldly than the adult or more efficiently than the adult. So when you need to transplant, suppose you have leukemia, right? You have relapsed leukemia. For a 6-year-old child, he needs transplant. You can't wait. Then your disease will come back. You will not get a right window to do. So you have to be very window specific, and you have to go for transplant when it is really indicated. And particularly in thalassemia or something like that, if you're too much transfused, if your organ system started getting damaged, then late transplant is sometimes can be very detrimental.
Right. So like you are saying, it is very disease specific and symptom specific also.
Yeah, and what stage of the disease, what is the condition of the disease at that point of time? They are all very small things, but you have a very, I don't know this word small, it's a very important thing to navigate that which patient needs transplant, which patient don't require transplant. Yeah.
Right. So furthermore, is the procedure for collection of bone marrow or peripheral blood, as you mentioned, is painful for the donor or in any ways bad for their health?
Yeah, two aspects of this question.
Right, sir.
So, most of the cases, except thalassemia, most of the cases in hematological malignancies, and if you go to any BMT center, you will find at least 80 to 90% cases are the hematological malignancy. And there we always prefer the peripheral blood stem cell. So we don't collect stem cells from the bone marrow anymore from these conditions, for these conditions. So we collect stem cells from the peripheral blood, which is a very simple process. We give the patient, we give the donor an injection, which is given like insulin-like injection, basically subcutaneously for 4 days. And day 5, we collect the stem cell by simple like a platelet donation, what we do in the blood bank. So we put a catheter just in the hand. Yeah, there's like a blood donation like that, and we put and then we put the catheter in the just put the line to the machine, apheresis machine, and machine actually does the job. So which is like you just have to lie down in the blood bank for 3 to 4 hours, and your apheresis is done. So donor basically just finish the apheresis, we check the blood counts, we check the sodium, potassium, or calcium levels, and next day the patient can go home. And we generally don't call the patients from the follow-up or anything. Whatever we have taken, that is generates in the patient's body very well. And whenever we do the allogeneic stem cell transplantation, when donor is involved, we always check the donor status, donor's organ function, everything very carefully. And obviously, we always call that donor is fit to go for donate. That is most important. So we can't risk that doing sake of doing transplant. We never do. Any transplanters don't do any risks to the donor. So that is the whole thing. So donation is a very simple process, like a kidney transplant, liver transplant. What is surgery involved? You have to take out the kidney from the body. Here, no surgery is involved. It is a total medical management involved.
Which means you're summarizing it is no ways harmful to the donor. And
Absolutely no.
anybody can donate a bone marrow.
Absolutely yes. Absolutely yes.
Right. So there is one more question usually that the donors have, that bone marrow collection is done only through the spine and the route of collection does not vary.
Sorry, I didn't know. So bone marrow collection done from the spine?
Yes. The route of collection is always the spine.
Yeah, so when you do the bone marrow test, so don't, that I've seen this misconception happens when the patient stops. So bone marrow aspiration and biopsy is a test, which generally we do on the patient's body, right? To diagnose the case, how to understand the disease. So we don't do from the spinal cord. There is a place which is called posterior superior iliac spine, which is basically back side of the hip bone. So that is the area we do. Why? Because it is the safest area. There is no major organ involved. There is chance of bleeding is very less. And even also you bleed, you can give pressure against these bones. So bleeding can be stopped. So these are the reasons we use this area to be chosen one for the bone marrow aspiration and bone marrow biopsy. Bone marrow transplantation is an entirely different thing, which is the name of a treatment. So never just equate with the bone marrow aspiration biopsy with the bone marrow transplantation. So nowadays don't use the word bone marrow transplantation, use the word peripheral blood stem cell transplantation, which is a more, I think, scientifically appropriate terminology.
Very well understood, sir. And what are the challenges if one is unable to do a transplantation or is not willing to do a transplantation?
Look, in hemato-oncology or any benign hematology, whenever we discuss a treatment plan, and there is an algorithm, right? So this is the algorithm and this is the flow chart of the treatment. So when we talk about the transplantation, most of the time transplantation is a curative intent. So if you don't go for transplantation, then you have to look into whether any other treatment available which is equally effective like transplantation. So if not, then obviously transplantation will be the better option. So in your health, always you want to go for the best treatment possible, right? So that point of time, that particular disease, which treatment comes in the algorithm in most efficiently with the patient, that is more important. And whenever we talk about the transplantation, any transplanter before transplantation, check the recipient, check the patient very, very carefully. Do all the necessary tests to understand whether the patient is fit to go transplant or not. See, that is very important. In our country, what happens sometimes I see, this is a social thing. Sometimes family decides, okay, My father can't take the burden of the transplantation. So it is not a son's job or daughter's job. It is a doctor's job to understand whether this patient can go with the transplantation or not. I'm telling Dr. Krishna one thing. Just today I'm discharging one patient. He's 78-year-old. Aplastic anemia. There is a treatment called ATG infusion. It is injection, immunoglobulin injection. It's a type of protein injection, you can call it, which is a curable treatment. When I discussed with the family is very clear. Do whatever the best for my dad. And patient is a fit 78, very reasonably fit, very well disciplined. Family members are also very cooperative, and primary caregivers are also very sincere. And we successfully did that. We sent the patient. So biological age is not important. Sometimes, when even 40 years old patient also we see and say, okay, no, isse hoega nahi. He can't manage. But sometimes if it's 70 years old, he's fine. 70 is actually good 70. I use call good 70 or good 72, like that. So I think when the patient is there should be a free and fair discussion happens with the patient and the doctor, straightforward. And then the decision to be taken. It is not a unilateral decision, right? It is a mutual decision. I don't know if it's the right platform or not to say that, but I see in many of our Indian families, and now the nuclear families, the other member of the families are not very keen to do so much hospital, follow up, everything. And the simple answer, and they don't say, no, I don't want to get transplant done, but they say, mera daddy ko to hoega hi nahi. So just shrug the responsibility. So that's complex social thing sometimes. Sometimes, a lot of times I encounter in my practice. So it is a doctor's job to decide whether this patient will be able to take transplant or not. Not family members or neighbors will decide that who the patient, whether he is fit to go for transplant or not.
So we'll go on to the next question then. Are there chances of relapse in with peripheral stem cell transplantation? And if yes, what should be done?
So the question of relapse mostly comes in the category of so I'm giving an example of leukemia, right? So before this thing, there are many types of leukemia, right? Many types of leukemia, in which stage of the disease you are transplanting, what is the type of the disease, what is the conditioning chemotherapy you are using, a lot of variables, lot of factors. But yes, there are definitely chances of relapse is there. I fully agree that in transplantation in leukemia is not 100% curable. But yes, many of the patients, if you don't transplant, then you don't have any other option other than transplant to get cured. So that is the most important. So suppose one patient I'm saying that if you do transplant, you have 40% chance of survival, long-term survival. And if you don't do, you have a 0% chance. So 0 and 40, what do you choose? Right? The answer is very simple. So your counseling should be very straightforward. And one more thing is important, that when we talk about any disease or any leukemia or any disease, so we give definitely this is the percentage of survival. This is the percentage of TRM, transplant-related mortality. We always discuss about that. All the patients of the transplantation, we discuss TRM. What are the causes of the TRM, like a graft versus host disease, infections, viral reactivations, VODs, all these discussions we do in detail. And what are the long-term side effects, like infertility, everything we discuss with the family in detail before taking the transplant. So yes, relapse happens. But when the treatment is, transplantation is the only option to cure you, if it is 30%, 40%, I think it's a fair chance, because 30 to 40% you are comparing with the 0%.
Right.
That is most important.
So moving forward, like you mentioned, allogenic transplant and the matched unrelated donor. How easy is it to find a matched unrelated donor? What are the success rates associated? And what is the procedure to find the matched unrelated donor?
Match unrelated, yeah. So, simple. So, allogenic stem cell transplant, I told, but a donor involved. So, donor can be 3 types of donor. One is a sibling donor, sibling match donor. So, you have a brother sister who is having 10 by 10 match. It is the best possible scenario. So, in any family, if you have a single brother or single sister, then chance of getting full 10 by 10 match is only 25%. So, you have a bigger family, your chance theoretically goes up, but actually data shows no. So, it is 25% average. I have seen family when there are four brothers sisters, no one has matched, but one brother has matched another family, like that. So that is most important. So when we don't get a family full 10 by 10 match, then there are a lot of registries now, like Dhatri, DKMS. So we send the HLA typing report to these registries, and these registries are interconnected. So they have their database, and then they check whether this type of HLA report. So one more thing important with transplantation, we don't check the blood group first. Most important, we do the immunity check, which is HLA typing. So HLA matching, we check with other registries. If we get to know that, yes, there is a donor enrolled in, say, Dhatri registry in Mumbai. So then they just communicate with them and ask them whether you are okay to donate. Yes. Then what is the time period you can donate? So all these things. all these pains taken by the particular registry people, like NMDP, National Manual Donor Program Registry. So there are a lot of private registries, they're all interconnected. So we search and we get it is a free of cost. This another thing is very important. So by 2-3 days time, you will be getting to know that everything is done. These are the donors available. These are the address. These are the type of donor available in these registries. So mostly we provide the patient's age, patient sex, age in the report, blood grouping, and the CMV status if available. CMV is a type of infection status.
Okay. What is the approximate time as to that is, it might take for us to find a matched unrelated donor?
Yeah, so you came to know only a day or two.
Okay.
You searched, the mail will come with 24 to 48 hours whether the donor is available or not. Yeah. And it's free of cost. So then the question starts, if you say, okay, we want to proceed with this donor. So then that registry will contact with that person, whether the person is agreeing or not. There are some logistics issues are there. Sometimes they say, okay, I am I'm too busy, I can't donate in 3 months' time. I'm not in India, I can't. There are other things are there. But registries, the registry counselors are there, they move here and there and get the thing done. So we always say, when there is a will, there is a way.
Right. So next being the question, what is the expected recovery process after a transplant? How do it vary based upon the medical condition and the type of transplant?
Yeah. So medical conditioning, definitely important. Whether you are doing autologous stem cell transplant, whether you are allogeneic stem cell transplant, that matters. So autologous stem cell transplant, like a myeloma, lymphoma, most of the patients will go within 15 days or 16 days of the transplant. Mostly they are just out of the unit. Allogeneic stem cell transplant takes a little longer time. Say sibling allogeneic stem transplant take around probably 18 to 20 days time to go home. Haploidentical and the match unrelated donors sometimes take a little more. Say around 20-25 days is the optimum time period they are out. Unless and until they are getting some bad complications like infections or something else.
And how well these complications can be managed?
Yeah. So I can tell you my experiences. So complications in initial days, you can get the infection related complications. So infection is one of the most important, I will say, the barrier of the success of the transplantation. My ICU director, Dr. Vaishali, always says, the multi-drug resistant organism is enough to kill any transplant program, not a patient. So like that. So yes, so we are now getting more and more judicious using the early antibiotics. Where you can avoid antibiotics, we try to use that. We use a lot of other logistics to understand the patient very well. What is the patient's previous infection complications? What antibiotics patients previously got? Whether the patient has any fungal infection or not. So a lot of technicalities, background, the scene you have to do. You are doing the transplant fine, but you have to study the patient's file at least significant number of hours in your office room or at home to understand the patient better. That hard work patients may not see you doing, or you have to do to get a successful transplant program. So your question is very pertinent that what are the complications? So always the transplanters will know how to handle the complication. And most important, it anticipate the complication. Correct? You have to anticipate. Okay, the terrorist attack will happen. So you have to ready with all the drones, all the mechanisms so that you can counterattack the whole system. So anticipation of the problem is the most important thing in the transplantation. You should not allow the things to happen. You should do something, the thing should not happen.
Right.
That is the most important.
And so what are the recent innovations or advances in the field of stem cell transplants? So
recent innovation means, so a lot of wider uses of the antibiotics, antifungal. We learned lots now how to manage the graft versus host disease, particularly the haploidentical transplant, recent innovations of the PTCY technique. So there are a lot of innovations are happening which we can reduce the graft versus host disease, which causes significant number of patients to die. So these are all the scientific innovations that are going on to decrease the mortality of the patient during transplant or post-transplant.
And is there anything a next level to peripheral stem cell transplant?
Yes, CAR T-cell therapy, you are probably read in the newspaper today. So CAR T-cell therapy is already getting very much popular. And you know what are the indications of the CAR T-cell therapy. And in our center also, there will be a mock drill or mock trial will be there in the next week for the CAR T-cell therapy also. So we are also gearing up for CAR T-cell therapy.
That is really great to hear that we have one of the best doctors, trying to get in the field, taking it to the next level and helping the patients to get treated as soon as possible. So furthermore, there is one important question. Your experience is so vast that you must have had many more such objections that must have been to be highlighted today. So is there anything beyond these questions that might have come into your previous experiences and you think should be highlighted to the patients today?
So, if I summarize a little bit our discussion, so every disease, the bone marrow transplantation comes in that algorithm. Don't miss the algorithm. Follow the algorithm. The scientific research, scientific data work together, ultimately made this algorithm, a treatment algorithm of the particular disease. So, all hematologists don't do transplant, or all medical oncologists don't do transplant. But it does not mean that patient should not be offered the benefit of the transplantation. So that is one very important thing. Number two, I told you a few myths. It is not a surgery. It is a medical management. Challenges are there, but we are geared up already to meet the challenges. I know that many patients ask me, I shall be in the BMT unit totally lock and key. No one keeping anyone lock and key. BMT unit is not a jail. Patient can do all their activities. Some patients are doing studies also. Some patients are doing on-call meeting, Zoom meeting also. One of my patients was there in aplastic anemia boy. He used to study for all the routine classes. Everything used to manage from the BMT unit. So it is like that. So it is for the benefit of the patient, right? It is for the cure and the benefit of the patient. You can cure a lot of hematological disorder with the help of bone marrow transplantation. That is the most important thing. When you have the opportunity to get cured from a deadly disease, then why to wait for? Another thing I always tell my patient, in leukemia or bad myelodysplastic syndrome, aplastic anemia, these are like a snake, cobra. So either you will have to kill the cobra or cobra will kill you. You can't coexist. So that is the most important. When you have some weapon to kill the cobra, better to try to kill the cobra rather than getting killed by the cobra. I think I make this very clear to you.
Yes, very clear, sir. Thank you so much for your time and such an information that usually, not every time is available in such crux, such a crux format. So thank you so much, sir.
Thank you. Thanks a lot.
Friends, I would also like to emphasize that the information shared here is a general information on BMT, or correctly called as peripheral stem cell transplantation. There might be a variation for your case based on different factors like stage, spread, comorbidities, etc. Moreover, I would also like to emphasize that even though the technology has advanced, but still you should be in the best hands and the hospital should be well equipped to manage all the potential complications. And for sure, Dr. Sanyal is one of the best names in Western India. Moreover, he is also known for his candid and clear opinions that you might have observed in the video. So, if you're considering bone marrow transplant in the near future, why take a chance? Why not to have a second opinion from him before taking any decision? If you want to get in touch with Dr. Sanyal, you can contact us on the information given on the screen or available in the description of the video. Thanks a lot, guys. See you soon in the next video on some of the other advancements in the field of medical sciences. This is Dr. Khushbu from MedicoExperts signing off for now.